The mainstay of therapy for follicular lymphoma has relied on chemotherapy for quite some time. So historically, we were using chemotherapy and chemotherapy combinations by itself. One of the major step forwards in treatment of patients with follicular lymphoma really was the addition of monoclonal antibodies to chemotherapy. So there were a series of trials that showed no matter what chemotherapy was used, the addition of rituximab actually improved progression-free survival and even overall survival. More recently, the Gallium Trial tested obinutuzumab against rituximab as the antibody combined with chemotherapy, and what we learned from that trial was that obinutuzumab was associated with a longer progression-free survival. Did not at the time of analysis translate into improvement in overall survival. So I think at this point, clinical practice probably reflects individual preferences, although obinutuzumab did have a higher progression-free survival. For the time being, I'd say that either rituximab or obinutuzumab combined with the chemotherapy backbone is still considered standard of care. There's still a lot of debate over what chemotherapy, is the best chemotherapy, and I think that, again, there's individual physician preferences, but most people would consider either bendamustine, CHOP, or CVP as the primary chemotherapy backbones used. In my own clinic, we use bendamustine or rituximab, and we also use maintenance rituximab, which has been shown to prolong progression-free survival on the heels of induction therapy as well.
In recent years, there's been development beyond anti-CD20 agents with rituximab. We now have obinutuzumab, which has been developed and actually shown in randomized fashion to improve the progression-free survival in the first-line setting of follicular lymphoma. That therapy led to about a 4% absolute improvement in PFS at 3 years compared to rituximab, but it does have some potential downsides, including increased infusion-related reactions, as well as perhaps increased neutropenia and infection. And so it's really a risk-benefit discussion that you have with patients now that we have the longer-term follow-up with the obinutuzumab versus rituximab-based immunochemotherapy. So when we think about the Gallium data, in that trial compared obinutuzumab with chemotherapy compared to rituximab with chemotherapy, we now have longer-term follow-up, 3+ years, and it shows continued statistical significant benefit of obinutuzumab over rituximab in that setting, but the absolute benefit is about 4%. The overall survival at the most recent update seems to be overlapping as well. And so when I see a patient, typically discuss the potential for improvement in delaying future progression, but I also mentioned the potential downsides of obinutuzumab, which really are slightly higher adverse events, including things like infusion-related reactions, which are more with obinutuzumab. There may be also additional cytopenias, neutropenia, and so it is a balance between efficacy and safety in this patient subset. Based on the Gallium study, we do talk about progression-free survival benefit, and in some patients that have rapidly progressive disease that really fit that Gallium patient population, I do certainly sometimes consider using obinutuzumab. It's important to note that in the Gallium study, most of those patients had a higher volume disease. The median time from diagnosis to treatment was quite short in that study, so about 1.5 months, which is not a typical a patient population where patients might have disease being actively observed for years and years. And so if I have a young patient that's fit, that has a more progressive, early progressive presentation, I certainly consider using obinutuzumab with chemotherapy in the first-line setting. But for the majority of patients, I'm still holding on to the fact that overall survival is similar between the two therapies and that the safety profile seems to be better in the rituximab. And so for most patients, I'm using rituximab combined with chemotherapy in the first-line setting.
The Gallium trial was really one of the largest trials that's ever been done in untreated follicular lymphoma, and it was aimed to test the efficacy of obinutuzumab compared with rituximab against a physician's choice of chemotherapy backbone. So the chemotherapy included either CVP, CHOP, or bendamustine. But what the trial showed was that head-to-head, obinutuzumab actually led to a much longer progression-free survival than rituximab. Obinutuzumab combined with chemotherapy, is a highly effective regimen. We know that compared with rituximab, there's a slight increase in the rate of infusion-related reactions, but they're largely easily manageable and generally only occur in the first cycle of administration. There's also a slightly increased risk of neutropenia, but the overall risk of infection is not particularly different.
So the improvement in progression-free survival in terms of efficacy does come with a cost, a downside of obinutuzumab, and really that is on the safety in terms of side effects. With obinutuzumab, there is a greater risk of grade 3 or 4 infusion-related reactions. Compared to rituximab, it might be 6% compared to, say, 3%. There's also greater cytopenias, and the cytopenias can actually persist with obinutuzumab, including in the maintenance schedule, where you might have cytopenias, grade 3 neutropenia, in 15% or so of patients, which would be higher than what we see with rituximab. And so if you're going to use the obinutuzumab, there needs to be a little bit more closer follow-up in terms of side effects, cytopenias, infection, than what you might actually do with rituximab.